Good morning. We have three presentations by our sub-interns this month. They've all been outstanding. Our first presentation will be by Erin Perrin. He's a fourth-year medical student at Quinnipiac University. He's originally from the Philadelphia area in Bucks County. He went to undergrad at Michigan in Ann Arbor. At Quinnipiac, he's involved with student representation. He's involved with curriculum design and student wellness. In his free time, he enjoys hiking and being outdoors, and eating New Haven pizza and watching Phillies baseball. So, start off, Erin.
Okay, perfect.
Hello.
All right, good morning. My name is Erin Perrin. I'm a fourth-year student from Quinnipiac University. I want to thank everyone for welcoming me into the department over this past month. I had a very rewarding experience, and I really enjoyed my time here. I also want to thank you for having me talk this morning. So I'm going to be talking about opioid use in urology. I think this topic is more relevant and important than ever. And I was interested in exploring the prescribing practices in post-operative opioid use in urology, as well as explore where urology is in terms of current initiatives to improve opioid prescribing and try to mitigate the opioid epidemic that we're currently involved with. I have no financial interests or relationships to disclose. So first, I want to review some recent data from the U.S. Department of Health and Human Services. That was published in 2017, just to give us an idea of what we're working with in terms of the opioid epidemic. So in 2017, almost 48,000 people died from an opioid overdose, which is equivalent to about 130 deaths every day. 11.4 million people misused prescription opioids, and 2.1 million people reported having an opioid use disorder. Of the 11.4 million people who misused prescription opioids in 2017, 2 million of which were for the first time. Per 100 people in the United States in 2017, 58 opioid prescriptions were written, and 17% of all Americans had at least one opioid prescription filled. So now that we have an idea of exactly what we're working with in terms of how serious the opioid epidemic is, I want to take a longitudinal look at the opioid epidemic over the last 2 decades. So from 1999 to 2011, there was a fourfold increase in the number of opioid prescriptions in America. And that was mirrored by a fourfold increase in the number of opioid-related overdose deaths. In 2011, there was a major spike in heroin-related overdose deaths. That was due to the affordability and availability of heroin. And then in 2013, there was a spike in the number of opioid-related overdose deaths due to fentanyl, again, due to affordability and availability. But over that time, the trend of opioid-related overdose deaths due to natural and semi-synthetic opioids like hydrocodone and oxycodone has been steadily increasing. This graph is also important in terms of the heroin trend to realize that 80% of heroin users report first using opioids that were prescribed to them. So as medical professionals, we definitely have a responsibility to prescribe opioids smartly and discreetly. Now that we have had an overview of the opioid epidemic in the US, I want to take a look at this epidemic in Connecticut. So there's been a similar trend in Connecticut over the last 2 decades. However, there's been a more drastic increase in 2011 from heroin and 2013 from fentanyl. And overall, Connecticut is the rate of opioid deaths, opioid-related overdose deaths in Connecticut compared to the rest of the country is about 2 times greater. So 27.7 deaths per 100,000 people in 2017 in Connecticut due to opioid-related overdose deaths compared to 14.4 in the United States overall. Connecticut ranks 10th in the country as a state in terms of opioid-related overdose death rate, and 6th in terms of the opioid use and disorder rate. Opioid use disorder rate. As a state, as a county, New Haven County is doing a little bit below the national average in terms of how many opioid prescriptions we're providing per 100 people. So in New Haven, we're prescribing 54.2 opioid prescriptions per 100 people. Like I mentioned earlier, the national rate is 58 prescriptions per 100 people. The Connecticut rate overall is 48 opioid prescriptions per 100 people. So Connecticut as a state is doing pretty well. And New Haven County is doing a little bit worse, but still better than the national average. This is just to give us an idea of exactly where we stand in terms of prescribing opioids as a country, as a state, and as a county in New Haven. So although the majority of opioids are prescribed by primary care providers, including family physicians and internal medicine physicians, surgeons also are supplying a large amount of the opioids in this country. So according to the CDC, the most recent data from 2012 showed that almost 10% of opioids were prescribed by a group of providers considered surgeons. That included general surgeons, orthopedic surgeons, and 15.7% of opioid prescriptions fell under all others, which included urology, ENT, and OBGYN. So if we consider these numbers, the number of opioids that are being prescribed by surgeons and surgical subspecialties is very significant, up to 0.25% of all opioid prescriptions. Okay. And to better appreciate exactly what it means to be prescribing 1/4 of all opioids in this country and the effect that that's having on the opioid epidemic, it's important to consider how many of these patients are being addicted to opioids in the postoperative setting. So a recent and widely cited study done in 2017 in JAMA Surgery showed that there was about a 6% incidence of new chronic opioid use in opioid-naive patients after minor and major surgery. They looked at a variety of different minor and major surgeries and found that the incidence of refilling an opioid prescription 90 to 100 days out of surgery was about 6%. And there was no difference between the level of procedure, whether it was a minor and a major procedure. Notably, the only urological procedure or surgery that was involved in this study was a TURP. And these numbers fall in line with the 4 to 10% incidence in opioid, in previous studies that have shown a 4 to 10% incidence in opioid-naive post-op patients of becoming addicted to opioids, as well as falls in line with the 6% risk of becoming of chronic opioid use after 1 day of opioid use, according to the CDC. Although all of the CDC's guidelines are in relation to opioid prescribing in chronic pain, not in the postoperative setting. So that's important to keep in mind. The guidelines for postoperative opioid prescribing are very limited. So this brings me to the main questions I want to address today, which are how are we doing in urology in terms of prescribing opioids? And there have been a couple of very recent studies looking at this question. And the goals of the two main studies I'm going to talk about are, number one, to quantify the prescription opioids that are being prescribed postoperatively after urological surgery, and number two, examine the procedure-specific guidelines that these studies put out in an attempt to standardize how many opioids we're prescribing for specific procedures. So this study was done at UPMC, published in Urology a few months ago, and it looked at opioid-naive patients undergoing major urological surgery, including open and robotic prostatectomy and nephrectomy. A telephone survey was conducted 3 to 4 weeks post-op by one investigator trying to determine how many self-reported opioid use by patients. They were all prescribed 5 milligram oxycodone equivalents. Of note, the regional nerve blockade at UPMC is used in greater than 90% of these patients due to institutional guidelines. So the perception of pain may be different in these patients as opposed to other institutions where regional nerve blocks are not as prominent. So the results of this study show that were pretty significant. So the median oxycodone equivalents prescribed versus used for each of these procedures, most notably for a RALP, the median number, and oxycodone equivalent just in this study was a 5 milligram oxycodone pill. So for RALP, the median prescribed was 27, the median used was 4. And the interquartile ranges for all of these studies barely overlap, if they overlap at all. Overall, over 27 5 milligram oxycodone pills went unused in the study for a total rate of a 60% unused rate. Notably, the second goal of the study that I discussed was to try to identify procedure-specific guidelines for opioid prescribing. And you can see right here the recommendations for how many 5 milligram oxycodone pills should be prescribed for each of these procedures in order to satisfy utilization by 80% of patients. And the reason that they used the 80% cutoff was that there was a general surgery study done at Dartmouth in 2018 that said that by satisfying the utilization by 80% of patients, you would maximize pain alleviation while minimizing the number of phone calls that providers were receiving and their narcotic refills, which is one of the major provider level barrier to reducing opioid prescriptions. So it's also important to set these procedure-specific guidelines because there's also a lot of variation in opioid prescribing in addition to obviously overprescribing. And one of the first studies to look at variation in prescribing, in opioid prescribing in post-urological surgery was done here by Dr. Liebman and Dr. Mona Medina. And it was a retrospective study of almost 2,000 VA patients who underwent surgical management of nephrolithiasis, including ESWAL, ureteroscopy, PCNL. Interestingly, they found that total doses and median daily doses were similar among all treatment modalities, which in and of itself is an interesting finding, given that the amount of pain that a patient is probably expected to experience after an ESWAL is different than a PCNL. They also found there was significant variation in what kind of patients were receiving larger doses of opioids or opioids in general. So males were more likely to receive more opioid pills, and PTSD patients were more likely to receive opioids in general in addition to higher doses. So again, the variability in opioid prescribing is a strong indication that there needs to be some procedure-specific guidelines with regard to opioid prescriptions. Also, for like these post-nephrolithiasis surgical management patients, up to 6.4%, which is a pretty large amount, received greater than 50 morphine milligram equivalents daily, which is greater than 6 5 milligram oxycodone pills a day. Another study that I wanted to touch on, a recent study published in European Urology a couple months ago at Hopkins. This was a prospective study, again, looking at number one, trying to quantify post-discharge opioid use, and number two, to again establish those procedure-specific guidelines. So this study looked at 205 patients undergoing radical prostatectomy, 56 open, 149 robotic. They had a very successful follow-up rate of about 100%. The physicians followed up 30 days post-op by calling the patient similarly to the UPMC study to assess how many opioids the patient had used. So the results of this study, the mean oral morphine equivalents that were prescribed was 227 milligrams, and the mean used was 52.5 milligrams. And pretty strikingly, if we convert the oral morphine equivalents to oxycodone pills and look at the medians, a median of 30 oxycodone pills were prescribed for these patients, these post-prostatectomy patients, and a median of 3 oxycodone pills were used. So the Oriole study showed an even greater significant, even more significant opioid unused rate compared to the UPMC study, and that 77% of post-discharge opioids were unused following the radical prostatectomy. And there's pretty drastic graphic representation of the amount of opioids that were prescribed and the amount of opioids that were used. Additionally, this Oriole study also used that 80% cutoff, again, because it's a very important number to hopefully one day establish procedure-specific guidelines, and that we want to maximize pain alleviation in our patients, but also minimize the provider level barriers to reducing opioids, being like requests for narcotic refills and phone calls to providers. So they set their procedure-specific guideline for a prostatectomy at 112.5 milligrams of oral morphine equivalents, which is about 15 oxycodone pills. Definitely differs from the UPMC study, but it's definitely less than the amount that they were prescribing, which was 30. Interestingly, and just of note, before the study, all of the 27 urologists at Hopkins were surveyed with like the basic question of how many opioid pills how many 5 milligram oxycodone pills should you prescribe after a prostatectomy? And the average of their answers was 24 pills. That being said, they still prescribed a mean of 30 pills. This was the first time that also studies show that prescribing higher quantities of opioids was independently associated with a greater use, a 22% greater use per additional oral morphine equivalent. And both of these studies showed very poor appropriate disposal rates. 9% of patients reported appropriate disposal. So the conclusions, number one, Clearly, postoperative opioids are overprescribed in urology. There's a 60% overprescription rate in the excess opioid study at UPMC and a 77% at Hopkins. Opioid prescribing practices must change across all specialties, including urology. Although surgeons don't account for the majority of opioid prescriptions, I think it's important that surgery plays their role. And lastly, urology needs to identify, validate, and implement procedure-specific guidelines in terms of procedure-specific opioid prescribing guidelines. And just to quickly look at some of the current initiatives that are ongoing at an institutional level, Dr. Davies and at the UPMC team that did the first study I talked about, they've instituted an opioid-sparing radical prostatectomy that focuses on patient education, the use of regional nerve blocks, pre-op and post-op non-narcotic analgesia, and if narcotics are needed at all, they're used they're used for a short amount of time, and they're used in small doses as possible. And then on a more systemic level, there's the Michigan Open Initiative at the state of Michigan. The 73 major hospitals in Michigan, including the University of Michigan and Blue Cross Blue Shield, have an alliance to try to decrease the number of opioids that are being prescribed to patients. Again, through patient education, through increasing availability of appropriate opioid disposal. And they have made some recommendations in terms of how many 5 milligram oxycodone pills they think should be prescribed for the urological procedures, the prostatectomy, ureteroscopy, and vasectomy. But this is just based on expert opinion and consensus at these institutions. They're in the process of currently being validated. But there are guidelines for all of these procedures on the Michigan Open's website. And that's it. Thank you. Dr. Sprinkle.
Presentation. Thank you very much.
Thank you.
There obviously, if there's 6% of people
If there are 6% of people who after a single exposure can become addicted, we also know that patients have different pain levels. Did you come across anything that provide a tailored approach? So, covering 80% of people, that decreases the number of narcotics that we're prescribing, but still the majority of those people are going to get many more narcotics than they need. Did you come across anything that gave sort of a tailored approach? Is there a way to estimate what an individual might need or how many narcotics they may need?
So I didn't come across anything specifically looking at like that 80th percent, just because that was recently done in 2018, that 80% cutoff. But I mean, there is a lot of data. There are a lot of studies that have looked at like the characteristics of specific patients, if they're more likely to become addicted to opioids or not. But I didn't want to go into that for this talk.
Preston, this might not.
There's a lot of data though in terms of characteristics.
Sorry, this might not answer your question. But I know in Urogyne, their hospital use predicts their outpatient use, and I know that sort of makes sense. But if I have patients now that use nothing overnight after like a lab case that we did, they are so unlikely to need anything at home. And I know our cases are different from the cancer cases, but we send people home with like 5 pills now.
That was exactly what because I agree with that. I mean, we've seen that, and I just want to sort of make that point to the residents. I mean, you guys may be aware of that, but I'm not sure exactly what your prescribing patterns are because I don't talk to you about it in a detailed way, and it's changing. But I agree. I mean, we should be seeing what the patients need in the hospital and then decide.
This is just a plug for enhanced recovery too, because so they're in the much maligned case request form. You can put in ERAS meds, so you can put in pre-op Tylenol and gabapentin orders, and it can be used post-op. And there's some evidence that Tylenol and gabapentin pre and post-op are opioid sparing. So I think if we can reduce the amount that people use, probably be a good thing. I don't currently send people home on gabapentin. I don't know if you guys are doing that at all. But I do tell people to continue taking Tylenol. So my preference is to not send people home on Tylenol containing opioids. So that way they can use them separately.
Just so the attendings know, from an inpatient perspective, we usually send like prostatectomies and stuff like that anywhere between 8 to 12 pills. And we kind of look at what the requirements were. If they have a stent placement or a TURP or TURBT, we usually don't even send them home with anything.
All right, thanks so much. So we'll be continuing next with Hamilton Trinh, who's a fourth-year medical student at Wayne State in Detroit. He's originally from the Bay Area, graduated from UCLA just a few years after Dr. Mona Medina did. He's, as a medical student, he's did research with Dr. Humphrey at Henry Ford in outcomes and Botox. And in his free time, he enjoys Photoshop and watching Saturday Night Live.
Thank you everyone for a wonderful rotation. Today I'll be talking about treatment of overactive bladder refractory to initial surgical therapy. Special thank you to Dr. Ricky for her guidance. I have no financial disclosures. So for the agenda, we'll start with the case presentation. I'll then talk about the overactive bladder background and its treatments. I'll then go into the current literature on the treatment of overactive bladder refractory to initial surgical therapy, and then I'll talk about future overactive bladder therapies currently under investigation. The case presentation, 75-year-old female presents to Dr. Ricky this month for interstim removal due to pain and inefficacy. She had already failed 3 anticholinergics for urgency urinary incontinence since 2015. She did have a subjective improvement in urinary frequency, urgency, and incontinence after interstim stage 1 trial back in 2018. And so she underwent a stage 2 post-January implantation. She then had recurrence of symptoms during that time. And so she tried a Botox in 2019. It had no effect. Her past medical history is positive for peripheral vascular disease, coronary artery disease, and anxiety. She's had 2 bladder suspensions, one in 1999 and 2001. So the background on overactive bladder, it's a symptom syndrome that comprises urinary urgency, frequency, and often with nocturia and incontinence. It affects 30% of women and 16% of men in the United States. As seen in this table, its prevalence increases with age. So first-line treatment for overactive bladder is conservative. It involves behavior modifications such as fluid restriction, dietary management, and time avoiding. Second-line treatments include pelvic floor physical therapy and medications such as anticholinergics and beta-3 agonists. So third-line therapies are minimally invasive surgical treatments. They include sacral neuromodulation with interstim, percutaneous tibial nerve stimulation or PTNS, and intradetrusor Botox injections. So interstim is FDA approved for overactive bladder since 1997. It consists of an implanted pulse generator implanted in the buttocks with leads going into the S3 foramen as shown in this diagram. Electrical pulses modulate the reflex pathways involved in storage and emptying phases of micturition. 60 to 70% of patients with interstim experience greater than or equal to 50% improvement in their avoiding diary variables over a period of 5 years. So percutaneous tibial nerve stimulation, or PTNS, it's FDA approved since 2000. How it works is it's a 34 gauge needle electrode connected to an external control unit that delivers an electric pulse to the tibial nerve, as seen in this second diagram. And these electrical pulses travel to the sacral nerve plexus via the tibial nerve. 55% of patients experience moderate or markedly improvement in the global response assessment of their avoiding symptoms after 12 weeks. So intradetrusor Botox injections, they consist of Botox injected into the muscle of the bladder under cystoscopy. How the Botox works is it causes a neuromuscular blockade that prevents acetylcholine vesicles from being released at the presynaptic terminals. The success rate is between 70 to 80%, where patients, after their first injections, 3 months afterwards, experience greater than 50% improvement in urgency and urgency urinary incontinence symptoms. So the selection of a third-line therapy initially depends on patient factors, including age, comorbidities, and costs, as seen in this diagram. But there are the current unofficial recommendations for early to late non-responders is switching to another third-line therapy going back and forth. There are no official guidelines. The current salvage studies ongoing to a second treatment that I'll talk about next are pretty small studies. So the first study I'll talk about is on how well InterStim works after Botox. This is a study published in 2013 in the Journal of Urology. It's an observational study from 2005 to 2010 of 20 patients who had prior Botox, and they discontinued the Botox due to lack of efficacy, or they were unsatisfied by its temporary effect where they had to come back every few months for repeat injections. There was a 7 to 53 month interval between the Botox and InterStim trial in order to prevent any bias from the Botox. These patients all underwent percutaneous nerve evaluation or InterStim's time lead stage 1 trial for a week. And if there was greater than 50% improvement in episodes of leakage, they then received the InterStim stage 2 pulse generator. So, and 14 of the 20 patients received the implantable pulse generator since they had greater than 50% leakage improvement. 11 out of 14, or 80% of these patients, were subjectively satisfied 1 year later. So ultimately, about half of the original cohort benefited from InterStim therapy after Botox. This study also looks at InterStim therapy after Botox. It's published in 2017, larger cohort of 36 patients. Looked at patients from 2010 to 2015 who had prior Botox and had discontinued either due to a lack of efficacy or adverse events such as urinary retention. So 23 of these patients, or 64%, received the implantable pulse generator after experiencing greater than 50% improvement on their InterStim stage 1 trial. So they then compared, so there was 74% satisfaction on 1 year. So again, about 50% of patients benefited. They also compared the rates to their 47 Botox naive patients who were receiving InterStim, and so 33 of the Botox naive patients eventually went to receive stage 2, and also at 1 year, 25 out of 33 were satisfied at 1 year, so about 50% benefit. So both of these studies in 2013 and 2017 demonstrate that an InterStim trial after initial Botox has similar efficacy to InterStim in naive, to Botox in InterStim naive patients. So this is, I then looked at Botox after InterStim, which is the other way around compared to these first two studies. This is a study that I did with the Henry Ford Health System, looking at 18 patients who received Botox between 2013 and 2016 after a lack of symptom control with initial InterStim. These patients had their InterStim either removed or turned off, and then they received 100 units of Botox. 7 out of these 18 patients, or 39%, had subjective symptom relief under 2-month follow-up after the initial Botox injection. They had a decrease from a median of 11 voids per day to 8 median voids per day, although there was no statistically significant change in their incontinence. And for the group who found no relief or had adverse events such as urinary retention, they did have a weaker urinary stream, and were also had a higher frequency of straining to avoid on their AUA symptom questionnaire prior to receiving their Botox injection. And so the success, we defined it as a patient reported subjective symptom relief. So it was like we saw them in clinic, and then whether they said it helped them or not. We also had objective measures too, such as the AUA symptom questionnaires, the bother scores, quality of life scores, and pad usage. And so since one of the side effects of Botox is urinary retentions, patients who had difficulty avoiding are more likely to retain or have their symptoms worsen. So it was the AUA symptom scores were predictive. There was no gender difference for those who found symptom relief versus no relief, and there was no gender difference for their avoiding item scores. However, this was a lower success rate when compared to our 77 InterStim naive patients who received Botox, where 50 patients or 65% reported symptom relief with the Botox. So then I looked at PTNS salvage therapy after InterStim or Botox discontinuation. This study published in 2018 looked at 162 women who completed PTNS, and they found that 10 had prior InterStim and 30 had prior Botox injections. They found that prior InterStim or Botox patients were less likely to have a subjective symptom improvement based on multivariate analysis compared to patients who never had treatment before, to PTNS patients who had never had treatment before. There were no difference in objective measures compared to treatment naive patients in urgency, urinary incontinence, frequency, and nocturia. And then finally, I looked at the other way around, which is third line therapies after PTNS. There is a lack of published data on the outcomes for overactive bladder refractory to PTNS. The study from in 2018 looked at 112 PTNS patients, and they followed them, found that 18 out of 112 or 16% went on to Botox after discontinuing InterStim, and 6 patients or 5% went on to InterStim after PTNS. But the further clinical outcomes, such as their avoiding data, were not recorded. So on to future therapies. The first that I will talk about is on radio frequency ablation. This is a cystoscopic device with electrodes deployed in the subtrigonal space, and it ablates the subtrigonal space and the afferent nerves within it. So this study in 2019 looked at 35 women who had an overactive bladder refractory to medication. They excluded patients who were undergoing current Botox or InterStim therapy. 6 patients did develop side effects after the ablation. One having pain, one having vaginitis, UTI, a burning sensation, a urethral bulge sensation. One did have a UO obstruction from an undetected urethral seal that resolved with a stent. So at 6-month follow-up with the avoiding diarrhea data, there was a 59% improvement for the incontinence, a 39% improvement in urgency, and a 9% improvement in frequency. 70% of these patients had a greater than or equal to 50% urgency urinary incontinence improvement. And 75% of patients found treatment benefit on a 1 to 4 scale. So the second future therapy under investigation I'll talk about is implantable tibial nerve stimulators. This consists of an electrode implanted in the medial malleolus to stimulate the tibial nerve, and a wearable external control unit. So the current PTNS requires patients to come to clinic once a week for 12 sessions, 12 weeks, and then once a month of maintenance therapy. So that's inconvenient for patients, and that does lead to the discontinuation rate of PTNS. So the point of the implantable TNS is to have all the treatments done at home so patients are less inconvenienced. So this study looked at 34 patients who received this implant. They were implanted in the OR either under general or local anesthesia, depending on the physician's preference. The patients then went 6 treatment sessions, 6 treatment sessions a week, 30 minutes each for 3 months. Then they went 3 maintenance sessions a week for maintenance. So 71% of patients found greater than or equal to a 50% improvement in urgency or leakage at 6 months. 3 implants did have a wound complication, 2 resolved with antibiotics, and 1 had to be explanted. And there's also improvements ongoing for sacral neuromodulation and Botox, and that I'll briefly touch on. The Axonics sacral nerve stimulator is 60% smaller than the current InterStim stage 2 pulse generator. It's also rechargeable for 15 years. While the current InterStim pack is not rechargeable, it has to be explanted and a new one placed. There's also a liposomal Botox that's instilled into the bladder. It doesn't need a needle, which lowers the risk of bleeding and infection. The liposomes help the Botox cross the urothelium's relatively impermeable layer. So in conclusion, there's the current third-line therapies for overactive bladder include sacral neuromodulation with InterStim, intradetrusor Botox injections, and PTNS. Picking an individual third-line therapy is highly individualized. And switching to a second, third line after initial failure produces reasonable outcomes, although the success may be lower than the treatment-naive population. And RF ablation, implantable TNS, rechargeable sacral nerve stimulators, and liposomal Botox are all treatments that are undergoing investigation and can add to the toolbox of overactive bladder treatments. Thank you. Questions? Mr. Foster?
Yeah, so
What if none of that stuff works? There's also like returning to medications. Some patients are candidates for bladder augmentation.
I was part of the OAD so we put that in the guidelines. Obviously far out because it's a big operation that catheterized. That's just something augmentation is an option for medication or for patients with refractory urology. And in fact, in the guidelines, it said, well, sometimes you have to catheterize. You have to put a catheter, a little patient who is basically not responsive to everything. They allow to put a catheter. What's this rate? With augmentation, exactly. The problem though is that it's a trade-off. It's trading off lack of storage and some for lack of empty. Now they don't have to capitalize. Kind of like
All right, now we have Zhan Wu with our last presentation. Zhan's originally from Southern China. He moved to New York City when he was 11. He attended Brooklyn Technical High School, then went on to Brandeis University and is now a fourth-year medical student at Downstate. His research interests include prostate cancer and nocturia. He's an avid road cyclist and enjoys day trips to popular cycling destinations.
Thank you for the warm welcome, Juan. For those of you who don't know me, my name is Zhan. I'm the visiting sub-intern from SUNY Downstate. I want to thank everyone for having me this fun. I had a wonderful experience and I really did truly learn a lot. So my presentation today will be on the local treatment of oligometastatic renal cell carcinoma. I don't have any financial disclosure. I became interested in this topic through a patient that we saw who was a 71-year-old male with history of left RCC that was resected in the early 2000s, 2005. And over the past 15 years, he's without evidence of disease, but he recently presented with vague abdominal pain. His past medical history, family history, and physical exam are below. They're fairly unrelated and unremarkable. So in June of 2005, he underwent left radical nephrectomy, during which in St. Raphael's, during which a 6.5 centimeter clear cell RCC was removed. It was not penetrating the capsule or the renal vein. Subsequently, he was placed on a protocol of Q6-month renal ultrasound that had been consistently negative year after year, and even the last year we reviewed the imaging, it was negative. But late last year, he came to our office presenting with crampy abdominal pain and constipation. We really didn't think much of it. He bounced around between different providers and primary care until finally in June of this year, CT showed a new mass on the right side that's 2.1 centimeter, as well as a 0.8 centimeter mass in the pancreas that's suspicious for metastasis. So GI biopsy they biopsied the pancreatic lesion, which is confirmed to be metastatic RCC. So there's a question of whether this lesion in the pancreas is a synchronous lesion from the new right kidney mass or a metachronous lesion from the left side that's been removed over 15 years ago. So he has follow-up appointment with interventional radiology and oncology to discuss what to do. So my talk today will be mainly focused on local treatment of oligometastatic RCC. However, I just want to briefly touch on the management options that's available per the newest NCCN guideline that was updated in August, actually. And for metastatic renal cell carcinoma, the first-line treatment is systemic therapy. In the current era, this usually means TKIs, immunotherapy that targets VEGF receptors that have been implicated in renal cell carcinoma. These are agents such as sunitinib and pazopanib. There's been multiple randomized trials that prove its efficacy and improve survival. However, one of the major drawbacks of systemic therapy is systemic toxicity. A lot of the studies, over half of their patients had to reduce their medication dose due to side effects such as declining ejection fraction and hypothyroidism. So according to the guidelines, the options for oligometastatic disease includes metastasectomy, which is the older approach of the two. Recently, they updated the guidelines to include stereotactic body radiation therapy due to a few papers, translational studies showing efficacy and local control using SBRT. And finally, for patients with limited life expectancy, they can just go on supportive care if they don't want to proceed any further treatment. To begin, I just want to discuss surgical resection of metastatic lesion. This is the older technique. So I'm going to review a paper from 1998 from the Journal of Clinical Oncology, as well as a more recent paper that systematically reviewed pancreatic metastatic RCC. So it's more specific to this patient. It was published in 2009. So the first paper was a retrospective study including 278 patients that were seen in Memorial Sloan Kettering. These are all patients that had metastatic RCC that already had their primary lesion resected. And the authors compared the patients that had metastasectomy versus the patients who opted for no surgical treatment of their new metastatic lesion. They found that they compare complete resection and partial resection and non-surgical treatment. They found that the rates of 5-year disease-free interval as well as 5-year overall survival to be significantly better in the group that had their metastatic lesion resected. And further Kaplan-Meier analysis found that, you can see here, that among the group of 278 patients, those who had solitary lesions showed a much better overall survival compared to those who had multiple lesions. So what's the take-home point is? The take-home point is that complete resection of lesion in oligometastatic disease generally leads to good long-term survival. While they have patients that have multiple lesions and solitary lesions, the outcomes are significantly better than in those with solitary lesion. Metastatic, this is just the surgically treated patients. So this older study, the limitations are retrospective design as well as a heterogeneous cohort. Some of the patients that are included in this group already had systemic therapy in the form of radiation or chemo, so it can kind of affect the ultimate result. Moving on to the systematic review of the pancreatic metastatic RCC, which is more specific to our patient. This is a study from Denmark that systematically reviewed 170 articles that describe some form of metastatic RCCs of the pancreas. And this included 311 patients that were treated surgically versus 73 that were treated non-surgically. About 65% of them were solitary lesions. So the big result is that resection of the pancreatic mass resulted in 5-year overall survival of 73% versus only 14% in the group that opted for no surgery. It's really important to know that when you compare this outcome to other stuff in the literature, the 73% 5-year survival is a lot higher than after resection of RCC in like a different anatomic site, such as the brain or the lung. So in regards to the question of whether the lesion in this patient is currently metachronous or synchronous, this study in univariate analysis found that there's no difference in 5-year survival between those who had synchronous or metachronous. So it really doesn't matter, it's one or the other. Even though this is a systematic review, they took papers that were all low-level evidence. There's no randomized or prospective study. And most of the study has small sample size, less than 50 even. And a lot of these studies have missing values that precluded studies from individual analysis within the paper. So yeah, so they did like mention the difference between partial and complete pancreectomy, but I think there just wasn't enough data to do like a formal analysis because a lot of the studies had missing values so they couldn't do a statistical analysis with sufficient numbers.
There's some retrospective data. They're equally distributed, so they don't like preferentially favor the tail or the head of the pancreas. They're equally distributed throughout the panc. Yeah, I would imagine.
This kind of brings perfectly into stereotactic body radiation therapy. Traditionally, radiation therapy is not considered an option for RCC because it's radio resistant, but there's been some studies that show that SBRT in particular works a lot better in local control. They hypothesized it has to do with higher dose radiation to a smaller body area. And this could be a better option for our patient so that he doesn't need a Whipple. And to review the outcomes of this, I want to talk about an abstract published from a group in Cleveland Clinic in a conference in 2017, as well as a recent publication in Journal Urology from a group in Italy that study SBRT and using it in oligometastatic RCC. So the abstract was a retrospective study with very small numbers, 14 patients from Cleveland Clinic. They were all oligometastatic RCC patients that had local therapy. It's important to know that while they just say local therapy, 75% of these patients had SBRT. So they found that the median time of progression of disease after SBRT was 10 months, and 64% of the patients that were radiated didn't require any systemic therapy. This is at like a median follow-up of 39 months, so it's not that long, but it's quite enough. And the adverse events were very limited to nausea, vomiting, abdominal pain. So when you compare that to the adverse events of systemic therapy, they're very manageable. So the authors concluded that SBRT is safe and effective within the 39-month follow-up, and they were thinking that maybe this can be used as a temporizing measure before the start of systemic therapy. Similar to other papers, it's limited by a small sample size, and also the 14 patients, they received different radiation doses. There wasn't like a standardized dose of radiation, so we really don't know how much to give them. And there's limited follow-up, so we don't know what the 5-year survival data is. Moving on to the paper published recently in the Journal Urology out of Italy. It was a retrospective study with a much larger sample size of 58 patients. They basically included everyone who had 3 metastatic lesions or less, who already had resection of their primary lesion. 83% of the group had solitary lesions. So the result is, if I can just point your attention to the table, the progression-free survival at 12 and 18 months were 46% and 35%, which isn't great, but the more important result is the table on the right, which shows local control rate of 92% at 18 months. That kind of supports the fact that maybe this can be used to delay the start of systemic therapy. We can start with radiation and then maybe move on to systemic therapy once we find something on surveillance. And there was, like the abstract, there was no significant adverse events, no grade 3 or grade 4 adverse event. They were all nausea, vomiting, and I think 1 episode of pneumonitis. This study also had a heterogeneous cohort in that about half of the patients already received systemic therapy, so the outcome again can be contaminated by that fact. follow-up was also limited to about like 30-something months as well. So there's a group from University of Southwest, UT Southwest, that responded in an editorial comment to the Journal of Urology paper supporting the use of SBRT with their own institutional experience. They found like over 90% local control or something like that. So they recently started a phase 2 prospective trial. They intend to recruit about 50 patients, oligometastatic RCC patients, to receive SBRT. And they wanted to basically answer the question of whether SBRT can be safely given to delay the start of systemic therapy, with the primary endpoint of being what the time is after SBRT to start systemic therapy, with secondary endpoints being the usual oncologic markers that we see in literature. So it'll be interesting to see what comes out of this phase 2 trial. Can kind of give us more information on how to proceed with these kind of patients in the future. So what does this mean with the patient we're talking about today? So the literature shows that complete resection of oligometastatic disease shows good long-term survival, particularly for pancreatic lesion at 70-something%. It's higher than if you find RCC in different anatomic sites. Second of all, the more recent development is SBRT, which has been shown to be promising, although we need to do more study for it. It would be an excellent option for people who don't want to undergo surgery, or people who just have lesions that are hard to resect or unresectable. Some of the other questions that still needs to be answered in this area is whether truly, again, local treatments can be used to delay systemic therapy, and also whether should we be starting immunotherapy concurrently with local treatment, or should we use it as a temporizing measure? It would be interesting to compare the outcomes of those two. And finally, I think we should do studies to tailor our treatment approach to metastatic lesion in different anatomic areas. Metastatic lesions of pancreas is different than brain metastasis. So more information on that would be also very helpful. And these are my references. This is all I have. Thank you so much.
That was a great talk. Thank you very much. I think I can't believe I'm giving a historical perspective, but the historical perspective on some of this is very interesting to see how everything now is labeled oligometastatic disease. So it's a very popular kind of term, but I'm not sure it actually is applicable to, everyone's calling it oligometastatic, but these are actually metachronous recurrences, meaning it's a metachronous recurrence of cancer. Oligometastatic typically means you kind of have the primary and a low volume recurrence, but everyone's calling it that. So, that's kind of what it is. But there are many studies looking at metachronous recurrences, which are recurrences of disease, and there is disease-specific or site-specific outcomes. You probably didn't find it because you were looking for oligometastatic, but if you look at metachronous recurrences, whether it's in the adrenal gland, lung, bone, those all do have very different survival estimates based on metastasectomy and treatment. Bone has been worse. Lung is actually better. Adrenal is kind of the best. They didn't address pancreatic. They had sort of other organs. But I think one of the reasons that bone may have been bad historically is that we were not using SBRT at that time. So I think it would be very interesting to update some of that data. But this is not just in this case, but in many cases, there are popular buzzwords for what things are called, and it doesn't necessarily tell you the whole story. So you got to be careful when you're looking back and doing research and kind of reviewing the literature, that what people are calling things does change over time, and it's really the same thing, just kind of rebranding. Correct. So oligo is defined differently. So some people call oligo 3 or less sites. Some people call it less than 3. Metachronous just means that you have a recurrence of disease at some other time. It's a metachronous metastasis or a synchronous metastasis. Either way, it's a metastasis. So oligo, I think, typically denotes the volume. And number of sites. So not necessarily size, but number of sites is typically what we're talking with oligometastatic. And that's a hot topic in many diseases right now, because we're realizing that we probably can for low volume disease. There are other studies looking at, I think Phil Perazio actually published this when he was at Columbia, But if you kind of can get rid of, for people with multiple metastases, if you can debulk their tumor volume by greater than 90%, so get rid of the primary in addition to any major metastasis, those patients do significantly better. So it's kind of a similar thing. If people have low volume metastasis, if you can get rid of the volume, but the vast majority of their cancer volume, they tend to have significantly favorable outcomes.
What's interesting, I mean, there's, you know, so when you look at the pancreatic study, it's interesting how much of this is related to potential confounding about who you can resect, right? So it's not an uncontrolled decision to say, well, I'm going to resect. They're unresectable, potentially unresectable patients. So it speaks to the need to, you know, I don't know if a randomized trial is feasible here, but it's easy to sort of impute that, well, if you can resect these people, you will reach that outcome. But I mean, it's not a straightforward decision, right? So I think there are probably some people who are left. That probably explains the magnitude of that difference, 70-something% versus 13%.
But I agree with and appreciate your conclusions, which is that metastasectomy is very important role in metastatic renal cell, and it works out very well. And the introduction of SBRT is a great possible use moving forward.
I was going to make the point that to expand on what Mike was saying, I was going to ask you this question, but when you look at the studies, because I think you can never randomize these patients, that of course the ones who are getting surgery are different patients than people who are not selected to get surgery. So I think whenever showing the data, it's always nice to show disease-specific survival, and then concomitant with it, adjacent to it, show the overall survival. It's not a randomized study, so you can't say, oh, if the survival difference between the two curves was 36% and it was 36% better in disease-specific survival, then that accounts for the benefit surgery what gave the patient. It's not that clean, which you would be able to say in a randomized study because everything else should be equal.
Yeah.
But it should track to some degree. So I think if you had overall survival and disease-specific survival, and there was some accounting of that difference, then maybe you can start to look at that difference. But
I think one of the key, like the key take-home point about pancreatic metastasis is that it's favorable, right? So generally, when you see someone who has a pancreatic metastasis, it is a sign of favorable biology. It happens like typically years and years and years later. So if you look at the series of patients who have pancreatic metastases, it's generally like 5 years, 10 years after they've had resection of their tumor. And I would imagine that almost no matter what you do to them, you're not going to necessarily have a huge influence on the biology, right? So like the 5-year survival for patients who have resection of a pancreatic metastasis is like 70, 80% plus, right? People do well. And I wouldn't be surprised if the difference you're seeing there in like the study you showed where surgical resection versus non-surgical resection, just as Dinesh is saying, is a lot of potentially selection bias, right? So the biology of the tumor in those two groups was much different, right? So if someone has rapidly growing disease or multiple sites that you may not be they have a pancreatic metastasis, but also a lot of other stuff going on, you're not going to resect it. Someone comes in with an indolent, many years later, solitary metastasis that they get resection, and it may be biology that's separating those two survivals as opposed to the actual intervention difference.
patients who have metastatic RCC that are looking well when they come into the office and are 10 years out from their metastatic disease and alive. And I suspect that that's what drives a lot of those that had surgery. They look like good, healthy, robust patients to operate on. They get operated on, they do well, and probably many of them would have done reasonably well without surgery. They get lumped into that surgical group.